So I want to thank Greg and John both for an excellent prelude into what I'm going to be talking about, which is more of the practical application of OCT. And basically, I'm going to talk to you about how and when to use OCT to improve procedural outcomes. So this is how I use OCT. First of all, I use the device and the catheter for the entire procedure. It's not something that I do just to look for complications. I use it because it's going to help me with my pre-intervention assessment, my stent deployment, and complications and post-procedural assessment. And each of these have important outcomes to them. Pre-intervention assessment, I need to assess the plaque composition because it's going to decide for me how I pre-treat the vessel. I need to identify the reference segments in order to adequately size my stent, both length and diameter, and to ensure that I'm not landing my stentage, for instance, into a large degree of plaque or a thin cap fiber atheroma. Choosing stent size is exquisitely important because, as we've heard from Greg, your final minimal stent area is perhaps the most important outcome of PCI. And on the same token, stent deployment, we want to determine our expansion in MSA accurately and easily. Finally, complications and post-procedural assessments include identifying edge dissections and what to do with these and when to treat them and when to leave them alone, to identify tissue protrusion and what to do with these and when to leave them alone, and finally determining apposition and when this can be a problem for percutaneous coronary intervention. As Jonathan mentioned, it's important to familiarize yourself with this display. As mentioned, on the left-hand panel, you see the co-registered angiogram. The white dot corresponds in a pinpoint measurement to your cross-sectional area and your cross-sectional vessel on OCT. And as you can see here, I've done my reference vessel sizing. However, perhaps the most important feature of OCT is this automated measures of lumen. This will give you a 0.2 millimeter by 0.2 millimeter segmentation of the vessel with exact measurements of minimal lumen area, diameters, and percent stenosis if you're post-PCI. In addition, this bar allows you to spin around, giving you a three-dimensional assessment of the vessel. And as you know, the reason we take multiple views on angiography is to make a two-dimensional image three-dimensional, and this is something that OCT can do for you on a single angiogram, allowing you not to use extra contrast in multiple views. So I think it's critically important to understand on OCT what we're looking at, and this is an example of normal artery topography. OCT is quite simply a red light, and anything that's red will absorb the signal. Therefore, it's critically important to adequately clear the blood vessel of blood, and that's done typically using flush media such as contrast. Once we've got adequate clearance, we're able to get a very sharp image. Included in that on the outside is the adventitial layer. You can see on a wire artifact on the inside, the catheter itself, and then the layers of the vessel wall. So the lumen, followed by the intima, which is this homogeneous bright orange appearance, and just inside of that, a darker circular layer, which is the media, which is bounded internally by the internal elastic lamina and outside by the external elastic lamina. And these layers of the blood vessel wall are critically important for our stent sizing. Another very important thing for OCT is to actually assess plaque composition. Here you can see the typical of appearance of a fibrous plaque, which is a large homogeneous appearance. The external elastic lamina can be seen almost 360 degrees, and you can see some signal dropout. This signal dropout or attenuation is typical for the presence of lipid. This is the appearance of a fibrofatty lesion, whereas Greg mentioned earlier there is some difficulty visualizing the external elastic lamina, and that is because the light is absorbed by the large lipid component of this blood vessel wall. Perhaps the most important aspect of plaque composition assessment for OCT is its ability to identify calcium. Whereas sound reflects off of calcium, giving you a single or the appearance of a line, light is able to surround calcium and therefore gives you this typical appearance of a cookie cutter where you can actually looks like someone has punched out a layer of the vessel wall. When I'm teaching how to use OCT, I say if you can take a pen or a pencil and literally draw around any segment on OCT, that's typically calcium. And this helps you decide how you want to treat the blood vessel, whether you're going to use rotoblator or CSI or high pressure balloon inflation. Another important area to assess plaque composition is that of necrotic core. Here you can see a very thin bright orange line. This is the presence or appearance of a thin cap fibroatheroma. This is not the great area for you to land your stent edge because it will lead to dissection and potentially to distal embolization, and not a great area for you to use cutting balloons or high pressure balloon inflation. The next part of using OCT practically is to choose your stent length, and that is identifying your reference segments. And here, the most important part is actually the automated measures or automated lumen assessment. Here, the idea is to scroll your reference vessel markers to the proximal and distal lesion edges. Once you've scrolled there, you determine your initial lesion length, which here is 26 millimeters. Following that, you actually want to assess on the cross-section what your blood vessel looks like. And here you can see 360 degrees of external elastic lamina and a very good place to land your stent. However, when we go to our distal vessel reference,